Hello, in this video we're going to talk about thyroid nodules. A thyroid nodule is technically a goiter, which means an enlarged thyroid gland. A thyroid nodule can be defined as a nodular goiter. Thyroid nodule is usually identified by the patient on routine examination or incidentally on imaging such as a CT neck or CT chest. When someone notices a lump on their neck or thyroid, I guess one of the most concerning things is, could this be cancer? Majority of thyroid nodules are benign. Thyroid cancer make up about 5% of the cases, and there are factors that increases the suspicion of cancer, such as if the thyroid nodule is in children, young adults, a person with a history of radiation to the neck or head, and also someone who has a family history of thyroid cancer. A thyroid nodule is actually very common. 50% of the population have it, but only 10% can actually be felt. Like all thyroid diseases, it is more common in women, and the incidence increases with age. Majority of thyroid nodules, as we discussed, are benign, 95% of cases. Some common examples of benign thyroid nodules are thyroid adenoma, which can be a basic benign follicular adenoma, the most common cause of a solitary thyroid nodule. Of course, this adenoma can undergo mutation in its thyroid-stimulating hormone receptor, and can progress to become a toxic adenoma, which is also benign. A toxic adenoma is where the adenoma becomes hyperfunctioning and produces a lot of T3 and T4, irrespective of thyroid-stimulating hormone. Another cause of a thyroid nodule is toxic multinodular goiter. As the name suggests, toxic, here again, the thyroid nodules have autonomous production of T3 and T4. It's producing a lot of T3 and T4 irrespective of thyroid stimulating hormone. A thyroid cyst is another cause of thyroid nodule and essentially is a fluid sac. Another cause of thyroid nodule is Hashimoto's thyroiditis, which is an autoimmune disease characterized by antibodies against thyroid peroxidase and the thyroid gland, resulting in thyroid damage. This inflammation and damage to the thyroid causes the nodules to form. 5% of thyroid nodules are cancerous, and there are many types of thyroid cancer, which we will not talk about, but the most common thyroid cancer is papillary thyroid cancer. There are features of the thyroid nodule which may sway one to think that it is cancerous, and this includes being a non-functional thyroid nodule, meaning the thyroid nodule doesn't produce any thyroid hormones. Another feature of the thyroid nodule can be that if it's an irregularly shaped thyroid nodule, this also may suggest cancer. There are a number of investigations that can be ordered for people with thyroid nodules. These include thyroid stimulating hormone levels in the blood, thyroid ultrasound, a radionucleotide scan, also known as a thyroid scan or thyroid scintigraphy. There's so many names for it. A blood test looking at free T3 and T4, and for a definitive diagnosis, a fine needle aspiration of the thyroid nodule with an ultrasound. Because thyroid nodules are so common, not everyone gets a fine needle aspiration, and there are only specific indications for it. In the next part of this video, we will follow an approach to someone who presents with a thyroid nodule. This approach can also be used with someone who has a diffuse goiter as well. So we begin with the identification of the thyroid nodule through history and of course examination. Looking at the brain, the hypothalamus produces thyrotropin releasing hormone, TRH, which targets the anterior pituitary gland to release thyroid stimulating hormone, TSH. This thyroid stimulating hormone will then of course target the thyroid gland to produce T3 and T4. The first thing to order with anyone with a thyroid nodule or a thyroid pathology is thyroid stimulating hormone levels and a plus-minus ultrasound of the thyroid gland. If the thyroid stimulating hormone level is high or normal, an ultrasound should be ordered. High thyroid stimulating hormone should raise suspicion of hypothyroidism. The ultrasound helps assess the anatomy of the thyroid gland and the nodule and its adjacent structures. It provides more anatomical detail than the thyroid nucleotide scan. The thyroid ultrasound can help identify any suspicious features of cancer. Suspicious ultrasound findings include a nodule greater than 1 centimeter, solid and hypoechoic, a nodule that is large or rapidly growing, a nodule with microcalcification, a nodule with central vascularity, a nodule that is taller than it is wider. After the ultrasound is done, the next question to ask is, does this thyroid nodule meet the criteria for a fine needle aspiration? The criteria for a fine needle aspiration includes those suspicious findings we just talked about on ultrasound. So if yes, there is suspicious findings on the ultrasound, then a fine needle aspiration should be performed. If there is no suspicious findings and the thyroid nodule does not meet the fine needle aspiration criteria, then we just monitor the nodule and may repeat a thyroid ultrasound in a few months' time. Focusing now on fine needle aspiration, it is essentially where you use a needle and aspirate the content of the thyroid nodule with the help of the ultrasound. The aspiration is sent to the laboratory for cytology to see the cells in more detail. The fine needle aspiration results are then classified into what's called the Bethesda classes, of which there are 6. Class 1 is a non-diagnostic result, which means that probably insufficient samples were taken. In this scenario, it is advised to repeat the fine needle aspiration. Class 2 is benign adenoma. Class 3 is atypia of undetermined significance or follicular of undetermined significance. In this scenario, it is important to monitor the nodule. For classes 4, 5, and 6, which are follicular neoplasia, suspicious for malignancy, and malignancy, a thyroidectomy is advised. A thyroidectomy can be partial or complete, which basically means removal of part or all of the thyroid gland. Now to recap, we came down the pathway where there was initially normal or high TSH levels. Important that people with high TSH, high thyroid stimulating hormones, these guys should also be screened for causes of hypothyroidism, such as Hashimoto's disease, if indicated. Now let us follow the algorithm when there is low TSH. Low TSH, which is low thyroid stimulating hormone levels, should ring alarm bells for hyperthyroidism. Because remember, high T3 and high T4 will have a negative feedback to reduce TSH release. When someone has low TSH, the next investigation should be a thyroid scintigraphy. A thyroid scintigraphy is also known again as a thyroid radionucleotide scan and also known as a thyroid scan. Iodine is an important component of thyroid hormones. A thyroid scintigraphy is where a chemical tagged molecule such as iodine is given. Iodine is taken up by the thyroid gland normally. If the thyroid nodule does not take up any iodine, it is non-functional and means it does not synthesize or produce any thyroid hormones. The other side is an autonomous nodule where the nodule is taking up iodine to produce thyroid hormones. When a nodule has uptake of iodine on the thyroid scan, it is called a hot nodule and it is rarely cancerous. A cold non-functioning nodule, on the other hand, raises suspicion of thyroid cancer and should have an ultrasound with consideration of a fine needle aspiration for a definitive diagnosis. A hot autonomous nodule can either be taking up way too much iodine than the rest of the thyroid gland, or it is taking up iodine at the same concentration or level as the rest of the thyroid gland. To be exactly sure, it is advised that free T3 and T4 be measured. A normal T3 and T4 with low TSH is a clinical diagnosis of subclinical hyperthyroidism. Subclinical hyperthyroidism will require monitoring because subclinical hyperthyroidism can evolve and become hyperthyroidism. A high T3 and T4 with low TSH means hyperthyroidism. The nodule is responsible for producing excess T3 and T4. And because this is a nodule and it's taking up a lot of iodine on the scan, it is likely to be a toxic adenoma. Toxic adenoma is either managed by surgery, a thyroidectomy, or by radioactive iodine. In this treatment, radioactive iodine is given, which will be mostly taken up by the hyperactive autonomous nodule. The radioactive iodine will break down, emitting radioactive waves, destroying the tissue, thus hopefully shrinking the thyroid nodule or making it less functional. So we just looked at an approach to a thyroid nodule, and this same approach can be used for someone with a diffuse goiter. I hope this video was helpful. Thank you for watching.